It's Anonymous MD with Dr. T.
And Lisa.
Dr. T brings the real and refreshing insights, straightforward, evidence-based, and up-to-date. Now here's the doctor and Lisa.
Okay, everybody, welcome back to another episode of Anonymous MD with Lisa and myself, Dr. T.
Hey, Dr. T. Thanks for, chatting with me again. It's always a pleasure.
Always a pleasure. And as usual, we have a really good episode. We have a guest from New York City, and she is, her name is Carina Iskander, Dr. Carina Iskander, and she's currently the internal medicine chief resident at NYU Langone, Brooklyn. And she will be, in the next couple of weeks, graduating to become a critical care fellow through the pulmonary department at the same institution. And so before we say hi to Carina, since we're talking about New York City, Lise, why don't you go over some of the numbers that we've seen in terms of COVID cases and COVID deaths and how they relate to the overall picture in the U.S.?
Sure. So we all know that New York has been hit hard, and it's a city that a lot of people love. So it's something we've all really been paying attention to. So the CDC numbers as of this morning show that there have been about 208,000 cases, or reported cases anyway, in New York City, and that just shy of 25,000 deaths there. And to put that into perspective in terms of the entire American picture, there are just almost 2 million cases, reported cases again in the US, and about 110,000 deaths. So the deaths in New York are just shy of 20% of the total deaths in America. So I mean, that's a pretty significant number. We know New York's population is huge, but I don't think it has a 20% population of the US. So it's quite significant. And what an interesting time to be critical care in the pulmonary department. Carina, thank you so much for joining us. You're clearly busy, so we really appreciate it.
Thank you.
Thank you, Carina. Welcome.
Thank you.
Welcome to the doctor. So, Carina, usually we like to start off by asking our guests if there are any charities or other organizations that you'd like our listeners to know about, and just give you a chance to highlight those at this time.
Yeah. In terms of an organization I just want to highlight is in terms of blood banks, and for those who have donated in the past and to continue to donate. Think that donations have slowed down a lot given the quarantine and the COVID, which is completely understandable, but there's still a lot of patients who require blood transfusions. A lot of the COVID patients require a lot of blood transfusions. So I think it's important that we continue to donate whenever you can, whether it's plasma, whole blood, platelets, or any other products that you're able to give.
Oh, that's such an important reminder, Carina. Thank you. I think you're right. A lot of people are probably worried about exposing themselves at a blood bank, but we should remind everyone that they are, very well-trained medical professionals. There are huge organizations behind these blood banks that have every single level of protection available, and that you're doing a lot of good.
Absolutely.
Yeah. Thank you for that.
So, Carina, I understand that there was a little bit of an expedition of your chief residency into fellowship because of what was going on with the COVID-19 surge in New York City. So, I'm sure this is the point in time where Lisa would interrupt.
It is the point in time where Lisa's going to interrupt, because not everyone's a medicine nerd. We don't all know what the residency and fellowship business is. I mean, the fellowship of the ring, because I'm a literature nerd. So is that no? Okay.
Not quite. But it's similar to Canada, but in the US. So residency training after medical school, we undergo residency training in the subspecialty, whether it's internal medicine, family medicine, surgery, other subspecialties. And then after you complete that specialty training, Depending on what type of training you've done, there's additional training that you can do called fellowship. So for example, so Tim did family medicine, right?
That's right.
I did internal medicine. So I finished 3 years of internal medicine. There's an additional year called a chief resident year, which I'm currently doing, about to finish up. And then I'm going to be doing an additional 3 years of fellowship training in the subspecialty of pulmonary critical care.
Wow. So you just really,
So
really need to
basically,
love learning.
she's going from the top of the totem pole among all the residents back down to the bottom of the totem pole among the fellows and the attendings.
Yeah, it's intern year. Intern year is the first year of residency. It's intern year all over again.
That's right. So much
Yeah.
to learn, and yet you're going to make such a difference, because one day you're going to be one of the doctors running ICU units, which is something that is incredible, I must say. Something that I was never, never thought I would be able to get myself to mentally and emotionally. But I have spent my time during my residency and med school years on the ICU wards, and we see some of our most difficult cases there, and we also see some of our most complex social and family situations there as well. So we're going to ask you a lot of questions today and try and get as much insight as we can.
So
Yeah,
you guys were
absolutely.
saying that the graduation from residency was expedited. Now I know we all heard that story in Italy where they were just sort of pulling medical students out of medical school or residents out of
Mhm.
residency and saying, "That's it, you're a doctor, here we go," because the need was so great. So is it something
Yeah.
similar?
Yeah. So there was a lot of up training in a lot of different departments, basically for everyone. Kind of everyone was escalated to a higher level. Um, so during my chief residency year, they graduated me to something called a junior fellow. So basically, I was acting like a first year fellow, kind of with a bit of supervision, but had a bit more responsibility. There were senior fellows who were placed as critical care attendings within units, and they were running units on their own. They're pretty close to graduation, so they felt very comfortable doing that. Our first year residents were acting like they were senior residents. They did graduate medical students early, actually, as well, and they were brought into the hospital after some significant training. But it wasn't just the MDs. A lot of the nurses were uptrained, a lot of the physician assistants as well. Everyone kind of just took it to another level very quickly, within a week, or probably less than a week, within their 3 or 4 days. And that was, very, very daunting for everyone, for a lot of different people. You're learning a lot of skills, a lot of knowledge, trying to learn all of that in a very, very short period of time.
And
But
I
yeah, we
would
made it
also
through though.
assume that you're under. I would also assume that you're also under a lot of pressure, and this is completely unexpected. So I can't imagine the mental and emotional toll it must have taken on the entire frontline team. And we also love to just highlight that people in the dietary staff, the sanitary staff, the maintenance
Absolutely.
staff, the OTs, PTs,
Mhm.
PSWs. I mean, we shout out to all of them as well because of what they went through. But did you find this kind of natural ability for humans to be resilient and rise to the occasion happen right before your eyes?
Um, I did, but not. But there was a cost. Everyone was just trying to get through the day as best that they can. There was really a point, and it wasn't just our own institution, but I know throughout the city, where we were having multiple what we called rapid response calls overhead, which is when a patient's acutely declining and more staff is needed. Cardiopulmonary arrest called over. I would say nonstop. I mean, every 2 to 3 minutes, and that was very demoralizing for a lot of people. Like everyone's running around, and they're just hearing these constant calls, which means someone is dying, really. And just to see the entire building, the entire frontline staff, just take that emotional toll and still understand and still push through the day. Like you know, there's no explanation for that. It's really, really, it was really something amazing, but also like really sad to have to go through.
It's just
We went,
it's amazing the power of the human spirit, right? And that you guys, I mean, as a layperson, it's the fact that nobody I know as a layperson questioned the early graduations and the moving people up. All I know is that we were grateful to hear that that was happening, because we know that you're all doing your best, and that you're all so well educated and know when you need help. And so I think that's an important part too. So thank you so much for, I mean, braving that, and being resilient and being here to tell us about it. It's amazing.
It is amazing, and thank you from me as well.
Thank you guys. But you know, I played in the grand scheme of things, I played like a small role in everything that happened. And I think we were just very lucky with the types of leaders that we had within our institutions from many different departments, who thought and acted so quickly to be able to mobilize as many people in the most efficient way.
And so, you know, if I were to get into a little bit more of a technical question, you know, when I see the reports of deaths from COVID-19, clinically, my question becomes, what is the criteria we're setting to define a death from COVID-19? So, for example, is there a set criteria that you guys go by where somebody has to meet a checklist in order to be deemed death from COVID-19? Another way to think about it, another way I'm wondering in my mind is, if somebody is sent to the ICU, or less likely has an event on the regular internal medicine wards, and it's due to a heart attack or a pulmonary embolism or kidney failure, and yet they also tested positive for COVID-19, does that count as death by COVID-19, or is it specifically deaths secondary to the pneumonia that's caused by COVID-19 and the inflammatory reaction that it can trigger, which is known as ARDS, or acute respiratory distress syndrome? So this is something in my mind that I haven't been able to find literature about or read in the popular media. And I was wondering if you, being on the front lines of our ICU units, would be able to clear that question up a little bit.
Yeah, sure. So we don't have a set criteria by which that we attribute a death due to COVID, other than having a positive COVID test. There is usually some component of respiratory failure, but that doesn't have to be the main cause of death. We are seeing, you know, MIs in these patients. We're seeing massive PEs. We're seeing a lot of renal failure. And oftentimes, like those are really the causes of death. They are in the setting of COVID, and there usually is some component of respiratory failure, but not always ARDS, or even the ARDS improves, but the renal failure doesn't improve. And we believe that the renal failure is secondary to COVID. So I think we're still learning a lot, but usually there is some kind of component of respiratory failure. But if there is another trigger for the death and they have a positive COVID, we attribute it to COVID as a COVID death.
I think that's really that's an interesting question you asked, Dr. T. Actually, I wouldn't have thought of it, but so interesting. And thank you for that explanation, Carina. I think that, you know, that does sort of shade the numbers of deaths in a certain way for the rest of us. And just for some of the acronyms that you use there, PE is, I'm going to guess, pulmonary embolism.
Sorry. Pulmonary embolism, yes.
Okay. And the ARDS is acute respiratory
distress syndrome.
Okay, there I had half of it. So
let's go over those two terms just for our average podcast listener. A pulmonary embolism is when a blood clot goes through your venous system, and usually starts in a vein in one of your extremities and then makes its way to the lung, cardiopulmonary, or the lung and heart system, and causes a blockage there. And acute respiratory distress syndrome is an umbrella term we use when there's a huge inflammatory response in the lungs. And that could be secondary to a number of things. And we're finding that COVID-19 can cause it quite frequently. But again, acute respiratory distress syndrome, or ARDS, can also be caused by a lot of other medical conditions, and is usually a reason why patients are in the ICU to begin with. So I hope that clears that up for our listeners.
It cleared it up for me.
So
Thank
Karina,
you.
yeah, and that probably means that most of our other listeners are comfortable with that as well.
Mhm.
So Karina, I mean, there's a lot more going on now in the news cycle, and we're seeing a lot of protests, and obviously social distancing is maybe not as diligent practice as diligently these days. We're also kind of seeing a drop in the number of cases and deaths from COVID-19. And I'm wondering, are there any theories why that could be happening? Could it be that it is a seasonal virus? Could it be another reason? I'm just trying to wrap my head around those kind of contradictory results.
Yeah, I think that's a very big topic of discussion within the medical community. I think we're all just waiting with bated breath to see what is going to happen. Um, be, because as you said, like social distancing is not being followed as diligently. Um, but the cases decreasing and everything, I think, were because of how strict social distancing and quarantining and everything was. I think now also, I think there's a better system in terms of testing people who are maybe symptomatic and they're quarantining from the rest of their families sooner than they were before, because we didn't have the test as readily available. I think that in terms of the cases not increasing yet, I'm not sure if it's too early for that. Whether we're going to see it in the next month or two, what's going to happen, especially as New York State is starting to open. On Monday, we started phase 1 of reopening in terms of the state, and you see the cases climbing in other states that didn't have as strict of a quarantine or social distancing. So you see those states, their numbers are going up, and we just don't know how things are going to go. A lot of states have not reached their peak yet. So, but they do have, I think testing is more readily available for them. So maybe they would be able to handle it a little bit better, because in New York and other states, it kind of just hit us really hard when we weren't quite prepared for it.
And I guess the last question I would have is this question about herd immunity, which I'm not sure we know much about at this point either. It's a bit too early. We've talked about on previous podcasts how we're going to need some antibody testing over long periods of time to understand, how long people develop immunity, and if they develop immunity to COVID-19, and then the broader implications for our population in terms of herd immunity. But hopefully we'll get an infectious disease specialist or an immunologist on in one of our future episodes, and maybe ask them a little bit more about that for our listeners.
Yeah. I think that's obviously a very big interest in research right now. Antibody testing is becoming more and more readily available. There's some question about the reliability of it. And again, like you said, what does detection of antibodies really mean for any of us? Does it actually confer immunity or not? Or is it just confer exposure or confirm exposure? Yeah.
Thank you so much, Karina. I mean, I've learned so much today. I feel like Dr. T has as well. Less about the acronyms, but in general,
100%.
yeah, I think he has. And I think that for us to be able to get a window into what it was like at critical care in a Manhattan or in a New York hospital, is just so valuable. I think that seeing from each other's perspectives and understanding all of the things, all of the cogs and all of the links in the chain that are helping is so important. And it reminds us not to be so self-centered and to value what others are doing and the sacrifices they're making. So thank you so much for that and for your perspective. Really appreciate it.
Thank you. Thank you for having me. Thank you for letting me share.
It's always our pleasure. And, one thing I'll just say before we go is make sure you take care of yourself and your own mental and emotional and physical health, so that you're better able to take care of your team members and your patients and their families. And, we always preach and try to practice patience and empathy and just that human spirit of connectivity and connectedness, I should say, as we go through this time together. And but it all starts with you, Dr. Carina, and taking care of yourself. And we wish you all the best in your upcoming fellowship. And I think the world is lucky to have people like you, and you in particular, who are stepping up to take on these big roles. So thank you so much.
Well, thank you. Thank you for those kind words. And thank you for having me on so I'm able to talk about this. I really appreciate it.
Anytime. You come and find us when you have something to say.
Anytime. That's right. If any new information comes out, please reach out to us. We might even bother you a little bit and check in and see if there's anything that's changed.
Dr.
that
T
you could
never
come share
bothers
with us.
anybody. That's ridiculous.
No. I just message and ask nicely. That's all. Okay, folks. Well, another great episode.
That's right.
Lisa, pleasure.
Pleasure
Thank
as
you to Mike,
always.
our producer over at the Pod Plant. And once again, thank
Have
you,
a
Dr.
beautiful
Carina,
day.
for joining us. Have a great day, everybody.
Thanks for listening to the show. Subscribe wherever you're listening to the podcast. On YouTube, smash that bell. That's a notification button. Anytime the doctor knows something, so will you. Stay healthy. See you next time.